Welcome back to Diabetic Profiles. So today's episode is not a casual one, it's not a light one, and it's actually more of a diagnostic reckoning and differential one. And it's when a patient comes into your office or walks in with a black toe. When you see a black toe, what are you really looking at? It actually is not a toe problem when you see a black toe. It's actually a systemic vascular failure. And the toe, the cute little toe, is actually just simply brave enough to be the first one to tell the truth, the first one to like raise their hand in the class and say, I know the answer, right? So here's the problem. When too many clinicians see a black toe, people think gangrene immediately, right? Gangrene, infection, or amputation. And remember, this whole series is about limb salvage, amputation prevention, right? But also, when it comes to boards, when they present you with a black toe, they don't ask, what color is this toe or what is this, right? They ask, why is the toe this color? And that's something we all need to learn to do. Why is this that, right? Why is this that? Okay. So we're going to dismantle exactly the black toe completely. What's the black toe? Okay. And remember, a lot of people actually, on top of that, don't know how to diagnose even like, yeah, the digital ischemia on people of darker skin color, unfortunately. So hopefully we can get into that too. This episode might be a little long, but today we're going to dismantle the black toe completely. So we're going to talk about digital ischemia, acute embolism, and blue toe syndrome. And when it comes to acute embolism, people really don't think that much when it comes to feet, but it actually is because thank God I had some of the most intelligent people who taught me, especially during residency. I think residency is the best place to learn almost anything, especially when you're surrounded by incredibly intelligent people. And I remember I presented a toe to my attending, and he knew immediately. He was just like, "This is acute embolism," because I was just like, "Oh, I just didn't know." I was so impressed. But he was one of the best doctors I ever met, most intelligent, and then on top of that, most humble. And yeah, I was just like, "You are so fascinating." But we'll get into that. Someday, I hope they do like a mount to him or some type of big tribute to him because I think he's one of the world's most fantastic podiatrists in the world. But get into we're gonna talk about the mechanisms of the black toe, the risks, the workup, the treatment, the prevention, and what it means when you actually miss it. Okay? Because if you confuse it with other entities, not just you're gonna fail the boards when it presents that in the question, but you're gonna fail the patient and possibly fail their limbs as well. Okay? So, what is a black toe? Okay. A black toe is tissue necrosis. Okay. It's not bruising, it's not dirt, and it's not just poor circulation. It's actually cell death. And cell death happens when oxygen delivery fails, when there is a metabolic waste accumulates, when microcirculation collapses. But here's the teaching point: the black is the end and the diagnosis happens earlier. So by the time the tissue turns black, the pathology has already happened and been well established. Which means your job is not to treat the color, but to identify the vascular event that caused it, okay? But that's where clinicians get separated into categories: those who amputate the toes and those who save limbs, okay? Because I do believe boards test this relentlessly because it does make a difference. Remember, when you see a black toe, you're going to be in two different categories: the people who amputate the toes and the people who actually save the limbs. So, digital ischemia. Let's start with digital ischemia. This is the most common, but also misunderstood because of the black toe. So, digital ischemia is because of chronic arterial insufficiency. So, chronic, that means it didn't happen just overnight, okay? Chronic arterial insufficiency, it's not sudden, it's not dramatic, it's actually quiet, it's slow, and it's a progressive starvation. The arteries narrow, the lumen strengthens, the red blood cells stop showing up on time, and the tissue does not complain loudly at first. It slowly whispers, the toe slowly gets cold, slowly gets pale, slowly gets numb, and gets painful upon exertion. And eventually, if nothing changes, the toe tissue eventually dies. So, what is the mechanism when it comes to digital ischemia? So, ischemia equals reduced inflow, increased resistance, and inadequate oxygen delivery. I'm going to say that again one more time. Ischemia equals reduced inflow, increased resistance, and inadequate oxygen delivery. It does not equal infection, does not equal embolus, does not equal trauma. Again, let me say it one more time. Ischemia equals reduced inflow, increased resistance, and inadequate oxygen delivery. So, which patients are at higher risk of getting digital ischemia? This is going to be your classic vascular patient who has diabetes, a patient with a history of smoking or even actively smoking now, patients with chronic kidney disease, hyperlipidemia, and long-standing hypertension. This is peripheral arterial disease until proven otherwise. The clinical progression for this type of patient, you'll see pallor, dependent rumor, cyanosis, and dry gangrene, dry, mummified, and demarcated. This is not an emergency way in a way of like an embolism, okay? But it is a limb-threatening disease, okay? So when it comes to boards, right? You do not treat digital ischemia with amputation first. You treat the artery. So who you call? Not Ghostbusters, but vascular. Okay? So you optimize it. You call vascular. You optimize. They're going to optimize. I mean, just do vascular. Call them. They're going to do it all. They're gonna put the patient on antiplatelet status. They're gonna revascularize. They're gonna do make sure the patient has glycemic control, and hopefully the patient would stop smoking when they see that. But you image, you revascularize, the doctor, you continue to offload, and you protect the tissue while it declares itself. Okay? But amputation is a consequence. Amputation is not a plan. Okay? But when you see the black toe first thing you wanna do, contact vascular, especially if it's mummified and demarcated and dry, you have to get vascular because the first thing they need to treat is the artery because you don't know where the blockage is, where the poor circulation continues. And if you do cut before vascular is able to revascularize and to what's it called again? Like do an angioplasty or whatever and know exactly where there is reduced blood flow, you can cause a higher more proximal amputation because you're cutting before you know that the patient has good enough blood flow. Next is acute embolism. Acute embolism, this is where people fail. So when I'm talking about embolism, embolism is the most dramatic, actually the most dangerous, and one of the most testable when it comes to a black toe. An embolism is not a narrowing, okay? It's not a narrowing, it's a sudden stop. It's a clot that forms elsewhere and it travels. And when it lands, it doesn't negotiate. It blocks the artery completely. There's no collateral, there's no warning, and there's no adaptation. So when it comes to a classic board question when the patient presents with an acute embolism, the patient will most likely present with a sudden onset, severe pain, a cold toe may be pale or blue, and no pulses, okay? So this patient tells you the exact moment it happened. Doctor, it was fine, and then it wasn't. And where does the embolism come from? Keep this in mind. Boards love this. Atrial fibrillation, recent cardiac infarction, ventricular aneurysms, prosthetic valves, and infective endocarditis. And if you don't look upstream, you're going to fail that question. So memorize this. Embolism is a medical and surgical emergency. Keep that in mind. I wish people in underserved communities paid attention to this because I'm just the people that die because of medical negligence and that they just didn't know is not fair. And I get it, the world isn't fair, but I do believe it's every physician's duty to know as much as possible so that you can diagnose appropriately and actually save lives. That's the whole point of being a physician, is to save lives and to save limbs and save any part of your body. Okay? Is not to just have the name and do nothing and say I'm sorry or make mistakes on human bodies. I don't agree upon that. Okay? So every day should educate yourself. But an embolism is a medical and surgical emergency. So, what do you usually do when it comes to that? They have to start heparin immediately, call vascular surgery. They have to identify the source and prevent a reoccurrence of the embolism. Remember, time is tissue, delay the amputation, and if you miss it, you're going to lose a limb. Okay? Next, blue toe syndrome, another board favorite. So, now we arrive to the trickiest, sneakiest diagnosis of them all, the blue toe syndrome. So, blue toe syndrome is not ischemia, it is not an embolism, but it is cholesterol crystal microembolism, embolization. Okay. So, the mechanism of a blue toe syndrome is a plaque ruptures upstream, the cholesterol crystals shower downstream and then they lodge in the small vessels only. And this is why the pulses remain present. So when it comes to boards, right? Here's a little pearl when it comes to that. Blue toe plus palpable pulses equals cholesterol emboli until proven otherwise. I mean, we can make that rhyme right now. Blue toe plus palpable pulses equals cholesterol emboli until proven otherwise. See, it kind of rings a little bit. So triggers of this is a recent catheterization, vascular surgery, aggressive anticoagulation, and aortic manipulation. So why does anticoagulation can worsen this? Because the anticoagulation actually destabilizes the plaque, it liberates the cholesterol, and you can make things worse. So when it comes to the treatment, still I would just leave it to vascular. But here's where people make very devastating mistakes when they have blue toe syndrome. One thing you should not do, the things you should not do when you say blue toe syndrome, you do not rush to amputate, you do not assume infection, and you don't over anticoagulate, okay? You actually stabilize the plaque, you control the inflammation, you treat systemically, and you provide supportive wound care. Blue toe syndrome is a systemic disease with digital manifestation. So, also remember, so when let's talk quickly again about ABIs, okay? So ABIs, everybody should have an ABI table in their head, especially any provider when it comes to wound care, vascular, anything like that. So ABI in your brain, 1 to 1.4 is normal. Remember, it can be falsely elevated if there is calcifications, right? Zero point 0.9 to 1 is acceptable, meh. Zero point 0.8 to 9, there is some arterial disease and you have to treat the risk factors. Zero point 0.5 to zero point 0.8, there is moderate arterial disease. You have to refer the patient to vascular. And less than zero point 0.5, when it comes to ABI, the patient has severe arterial disease and you need to make an emergency vascular referral. Okay, so keep that in mind. So let's talk about some diagnostic algorithms when it comes to this, okay? Because now you understand the mechanism, right? The differentials and the mechanism of a black tail, right? Let's talk about how you're supposed to think. Remember, you're supposed to think of why this happened. Why is the toe looking like this? Because remember boards, that's why boards, it is difficult to pass boards because it doesn't just test your memory, it actually tests your critical thinking and sequence and they're asking why. You have to understand the mechanism and everything, okay? So here's the sequence. First, you have that question, is it acute or chronic? So if the patient tells you it happens suddenly, you're already in embolism territory, right? If the patient tells you it's been getting worse for weeks to a month, you're in ischemia territory. The second question are the pulses present? Here's another thing. When it comes to pulses, especially in the feet, just test them. It will save anybody a lot of time, even when it comes to malpractice. Just test the pulses. You have hands. and you have two of them. Use them. Touch the DP, touch the PT. If you don't feel it, it's non-palpable. Hopefully everybody would have a Doppler by, and then you can hear it, okay? But yeah, use your hands, okay? Remember, medicine has become less touchy, right? But early medicine, they had to use their hands a lot. Touch the patient's foot. Feel the pulses, okay? So are the pulses present? This is not an option, okay? This is not extra credit. This is actual a question that comes with you helping your diagnosis. I have yet to meet somebody unable to fully diagnose somebody properly without knowing their pulses in their feet. So if the pulses are absent, think large vessel disease. If the pulses are present, think small vessel disease, okay? And another clinical pearl when it comes to board that you must tattoo in your head is that blue toe with palpable pulses equals cholesterol embolization until proven otherwise. Okay. And the third question also you need to ask is, was there any recent vascular insult, such as a catheterization, angiography, stent, bypass, anticoagulation initiation? If yes, your suspicion of blue toe syndrome skyrockets. It's not going to be subtle, it's going to be a pattern of recognition. So, when it comes to ordering things like an ABI, a duplex, a CTA, boys love imaging. Don't we all, right? We're all visual creatures, right? But they love when you order the right test for the right reasons, and that's how it's supposed to be. So let's start again with ABI, which is a screening tool, not a diagnostic, really. So ABI, like we said, if it's less than zero point 0.9, you do less than zero point 0.9, you do have to think about peripheral arterial disease, and if it's less than zero point 0.5, you have to think of critical limb ischemia. But remember the diabetic trap is that with medial arterial calcifications, the patient's ABI gets falsely elevated. So the ABI might look normal, but the toe looks dead, so you can't trust that. So what do you do next? You have to do a duplex ultrasound. So this tells you a duplex ultrasound, what does it tell you? It tells you the flow, it tells you the velocity, and the location of the stenosis, so where the blockage is. This is good for chronic ischemia. Follow-up is a non-invasive evaluation. Then next comes a CTA or MRA. So a CTA answers the question, where is the blockage? Is this blockage embolic or atherosclerotic? And then can this be revascularized? In my opinion, I'm hoping that it can, okay? Because like I said, vascular is doing God's work and I need them so much. I am so grateful for vascular. And I know people are so tired of me chiming in and saying vascular, 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 but they are like gods. I wouldn't say like that to be blasphemous, but they are amazing. They move something dead to life again. Okay? That's why we all need vascular. And if you suspect an embolism, image the heart. Echo is not optional, you know. The toe is not the source, it's the victim. Just keep that in mind. So let's run through some quick cases for boards. I don't even know why I just started thinking about that for some reason, but boards. But let's run through some classic cases. So case 1, a 72-year-old male with diabetes, history of smoking present, presents to you with a black, dry, painless toe. Pulses are weak. ABI is zero point 0.4. What is the diagnosis? Most likely chronic digital ischemia. What is the management? Optimize vascular status, revascularization if possible. I'm not vascular, so contact vascular. Do not rush to amputate. Case 2, we have a 65-year-old female with atrial fibrillation, presents with a sudden severe toe pain. The toe is blue, cold, and pulseless. What are you going to think? Acute embolism. What is the management? Immediate heparin vascular consult source control. Case 3, another board favorite. A 70-year-old man develops a painful blue toe 2 weeks after cardiac catheterization. Pedal pulses are present, renal function is worsening. What's the diagnosis? Luteal syndrome from cholesterol emboli. So management would be supportive care, plaque stabilization, avoid unnecessary anticoagulation, and treat systemically. But no matter what, you're going to have vascular right by your side, hand in hand, walk hand in hand with vascular. So if you amputate this toe early, you already failed. You failed the patient and you failed the board. So yeah. So now let's talk about the part that boards don't test really about, but the patient lives with. The most common failure in a black toe management is premature amputation. Amputation before actual diagnosis is just laziness, in my opinion. Okay? And I'm sorry, but I think everybody should know that. You should know not to amputate before you diagnose the patient, right? Every toe, I mean, there are cases of medical emergencies like gas, things like that, right? Okay. But you should be able to know how to manage all of that too. These are complex cases. You're a physician. So every toe you amputate without understanding the mechanism, like why this toe looks this way, why this toe presents this way, why this toe is colored this way, you're missing the embolotic source, you're missing the systemic disease, and you're missing a chance to save a limb. Okay? And to be honest, who wants to be known as the person who amputated a bunch of limbs? I'm just kind of confused by that. So you're pretty much a taker than a giver when you just keep on taking a bunch of limbs and parts of people's bodies instead of saying like, I've yet to meet a patient that's like, "Oh, I'm so happy they removed this part of my body." I've only heard patients rave about people who was like, "Oh, everybody else wanted to amputate and they saved this. They just wanted to take away my leg and this doctor begged to differ and they able to save my foot." Things like that. They remember the people who made them feel like they can live again, not the people who made them feel like they were just a number, any other patient and didn't care about the patient's quality of life. You have to think about the quality of life, what they want, what this amputation represents to the patient, and what does saving a limb mean to this patient as well. But toes never lie, in my opinion. Okay, toes tell the truth, and toes are like a never-ending story in wound care, okay, and limb salvage. So a black toe is a warning shot. If you silence it without listening and figuring it out, the disease is going to speak louder, and you're going to end up even like that's malpractice, to be honest. So next time, think thoroughly: leg, kidney, heart, brain, everything. Okay. So prevention is better than cure. I get it. Prevention is not glamorous, but it is powerful. So you prevent a digital ischemia by controlling the diabetes, treating the peripheral arterial disease early. And how do you do that? Vascular. Stopping smoking. I hope every patient hears that. And then managing the lipids aggressively. How do you prevent embolism? The patient should be on proper anticoagulation, rhythm control and atrial fibrillation, and valve surveillance. And then to prevent a blue toe syndrome, you prevent that by gentle vascular intervention, plaque stabilization, and respecting the aorta. And most importantly, you prevent amputations by thinking before cutting. Like I said, I met this. Not even a met. I watched this. It's a conference or a seminar by a doctor, and he just said before you amputate, hesitate. I'll just never forget it. And he was showing all the cases that he did, people that they wanted to amputate the limbs and digits of, and he was able to save every single one. There were ones that I even said myself, I was like, there's no way he saved that. And he did. And I'm just in complete awe of this man doing God's work. And he's amazing. Like if I had any patient that I was just like in doubt, I would contact him. But let's get back to the final truth of the matter. A black toe is not a wound. It's a vascular confession from your foot. So if it's telling you where the blood is failing, where your judgment matters, and where time is being lost, okay? Because your job is not to remove the evidence. Your job is to understand the crime, what's going on. You need to understand the mechanism. You don't just stay toes, you're saving the leg, the limb, the life, the patient's future, okay? Because it's not just a black toe, it's a vascular systemic failure. Okay, so keep that all in mind. So let me do a few quick, again, forward questions. Okay, 68-year-old man with longstanding diabetes. 4 40-pack year smoking history presents with a flat, dry, painless distal hallux. The toe has been discolored for several weeks, and the pedal pulses are diminished, and its ABI is 0.42. What is the likely mechanism? It's going to be a chronic arterial ischemia. The reason why is because it was a gradual onset. There's dry gangrene, diminished pulses. The low ABI indicates progressive peripheral arterial disease related ischemia, not embolism, not infection. 72-year-old female with arterial fibrillation presents with a sudden keyword, onset of severe toe pain. The toe is pale, cold, and pulseless. The patient reports pain that began out of nowhere about an hour ago. What's the next best step for that patient? You got to start them on IV heparin and consult vascular. What is it most likely with the sudden onset? It is acute arterial embolism. Limb, remember, it is a medical and surgical emergency. Needs immediate anticoagulation and surgical evaluation. Okay, so call vascular. Next, a 70-year-old male with a painful blue toe discoloration on multiple toes for 2 weeks. After cardiac catheterization, pedal pulses are intact. Creatine is actually increased. What's the most likely diagnosis for this patient? Cholesterol embolism, aka blue toe syndrome. Explanation, remember, blue toe plus intact pulses plus recent vascular procedure plus even renal dysfunction is the classic cholesterol microemboli. Which feature best differentiates a blue toe syndrome from acute arterial embolism? Palpable pedal pulses, okay? Blue toe syndrome affects the small vessels, leaving the large arteries patent and the pulses intact. So, a patient with blue toe syndrome is mistakenly placed on aggressive anticoagulation, forgive me. What is the most likely coincidence of placing this patient on that? Worsening of the microembolism. Anticoagulation therapy can destabilize the atherosclerotic plaques and increase the cholesterol embolization. Which patients are at the highest risk for acute digital embolism? A patient with arterial fibrillation. Okay, arterial fibrillation is actually a major source of cardiac embolism events. Which diagnostic test is most helpful in identifying the source of an embolic black toe? I'm just going to go through the multiple choice questions. A, ABI, B, a toe pressure, C, a plain radiograph, D, echocardiogram, or E, ESR. The answer, what do you think the answer is? Is going to be echocardiogram. Ec- Embolisms are often cardiac and require cardiographic evaluation. So you need to get an echo. A diabetic patient presents with a black toe with a normal ABI. What is the explanation? That should be like ABCs by now. The ABI was most likely falsely elevated due to the calcifications. Medial arterial calcifications in a diabetic patient can produce a falsely abnormal high ABI. Okay? What is the most appropriate management strategy for chronic digital ischemia? Going to be vascular optimization, so contact vascular, revascularization, and risk factor modification. And then last but not least, the black toe represents which of the following? What does the black toe represent? Isolated podiatric pathology, primary dermatological disease, end stage vascular failure, local trauma, or E, acute infection. What does it represent? It actually represents an end stage vascular failure. So a black toe, if anything else, a black toe is a manifestation of a systemic vascular disease, not an isolated foot problem. They just are the tattletale first, okay? So clinical pearls, blue toe plus pulses equals cholesterol emboli. Sudden pain plus cold toe equals embolism. Gradual blackening and peripheral arterial disease equals ischemia. Never amputate before diagnosing the mechanism, and the toe is the warning sign, not the disease. Okay. So this is diabetic foot file. I really hope this episode will help save somebody's toe and their life. And this is Dr. G. Take care of your feet because it takes care of you.